Not bring it. All right, can everybody kind of see? You've all seen this already in real life, so. Yeah, there's lots more room, come close. All right, this is tissue from a sheep. We have a lung. Did anyone see any postmortem artifacts this time? Not really. Thoroughly describe any lesions you see. So these lungs are mostly normal. We've got a little bit of thymus. Did everyone see thymus? Here is another tissue. We've got some trachea. We've got a little bit of esophagus. We've got some great vessels. This is called a pluck. It would be if it had the tongue still on. So pluck is from tongue to lung. That all comes out as one piece and we examine it. Heart is gone. So here we have some lungs. They have been bread loafed. So this is how we examine large tissues. And this is fallen out now, but this was in the trachea. Did everybody see that? How did you describe this? It's kind of wormy. It's stringy, white. It's pretty soft and friable. And it was just kind of laying in the tracheal lumen like that. We'll put it back for the next class. Do you even know what that is? It's fibrin. So we're going to talk about that in acute inflammation week. Fibrin is the plasma protein that clots your blood, and it participates in acute inflammation. So the fact that there's fibrin in the trachea tells me that there's inflammation going on in these lungs. Fibrin is being exuded. So that's an indicator that these lungs are maybe not normal. And then did everyone see these little red spots? Multifocal little red spots, kind of mostly in the caudal lobes. They range in size. They're fairly well demarcated. They are flat. So if I run my finger over the surface and look away, I can't feel that there's anything there. So they don't really have a texture. And that's how I would describe these lungs. This animal, I believe, was septicemic. So sepsis causes inflammation in the blood and in the whole body. So the site of infection was actually distant from the lungs, but the effects of systemic inflammation on the body have now affected the lungs separately from the bacterial infection that has gone on. Anybody have any questions about this specimen or this case? Yeah.
The fibrin isn't just specific to lungs, we'll see that in other tissues
No.
as well.
So all the processes we're talking about, none of them are really going to be specific to an organ. Some of them, like lipid and amyloid, might have a preference for certain organs, but all the processes we're talking about in this class can happen anywhere in the body. So that's what we're focusing on is foundational approaches that you can use in every organ, right? When you see fibrin being exuded, that tells you that there is acute inflammation happening in the tissue. Sorry, Zoom land. I've been standing in front of the camera the whole time. Work in progress. Any other things you'd like to talk about with this specimen? Or somebody picks me another one.
Is that like a normal color lung?
This is a normal color and it's a fairly normal texture. I showed a couple people the way to correctly fondle a lung is you want to take the lung tissue like this, you want to take your hands like this, and you want to just gently kind of slide it through your fingers. It's very sensual, the lung. You don't fondle a liver like that. The liver is more of like an S&M kind of thing. It wants aggression. The lung, be gentle. So you're going to kind of go like this and just kind of fondle. And I'm feeling for crepitus. You guys learned that word yet? That means air bubbles, which in a lung is normal. I'm feeling that the crackling of the alveoli popping under my fingers. There's not a lot in this one because it's been sitting in a bucket of juice for a couple days now. So we've kind of filled all the airways. But a normal healthy lung should be about this color. It should have a nice crepitant texture when you feel it. And some people probably saw this. It should also have like a nice little like jiggle to it. Hear that sound? It's kind of a dry sound. A normal healthy lung should be fairly dry. If your lungs are wet or heavy or like the surface is shiny, you have pulmonary edema. If you have foam in the trachea, foam is water mixing with air. Air is in here. You add water to the lung, you get foam. So foam in the trachea tells you there's pulmonary edema. So that's kind of how we're using these descriptive things and these findings to make inferences and do detective work on the cause of death. Make sense? Okay. Another? Bring me another.
Another one. When you're doing your
Yeah.
preface check.
You'll feel that. You'll feel nodules, you'll feel fibrosis. Fibrosis is scar tissue. It's going to be very, very firm.
So is it harder to pop the alveoli?
So the reason we're feeling alveoli is we're trying to decide how much air is left in the lung and has it been replaced by any. So your alveoli can be flooded with things like fluid. Pulmonary edema will have reduced crepitus. Hemorrhage will have reduced crepitus. Lots of things can cause reduced crepitus. We're looking primarily for more like infiltrative things rather than like mass or something. Does that make sense? Oh, I love this one. All right, so this is a cow jaw. Can someone bring me the normal jaw that we had too? Because I think people kind of struggled with this one. So this is a jaw. We have removed almost all of the muscle. This is mostly just bone and mass left. There's a little bit of muscle right here that we couldn't get off, but this is mostly just bone. So when we're playing spot the difference, got my lovely assistant here. So hold up the mandible so they can see it.
Over here.
Here you go, Zoom friends.
Oh.
So here's our tissue, and then look side by side. So one of the common things you'll hear me say over and over as approach to lesions is, has something been added from the tissue or something lost? So what do we think when we're doing a side by side? We have added hella tissue to this thing. It's even super heavy compared to that. So describe it. What kind of descriptors would you use if we're doing spot the difference and this is that? What would you say about this? What are some words people use? That's a noun. It's an interpretation. Firm. Firm to hard. I think some parts of this are hard. I think there is bone in here. Did I hear multinodular? Great. Perfect. I can see discrete nodules on the cut section here. How about the color? Gross. I can't draw gross. It's like dark gray, brown, black almost on the cut section. It almost looks like muscle. It's like dark red. Very, very firm. Is it focal, multifocal, diffuse? It's multifocal. Yeah, you could make an argument for regionally extensive because from here out is normal and from here back there's like no normal left. But it is multifocal. We have multiple coalescing nodules. I usually consider that multifocal. It's massively enlarged. Yeah. So kind of a pro level tip. When I do my descriptions, I usually start by describing where I am in the tissue and what's the distribution of the thing. So my first sentence for this lesion would be the, let's see, it's the, I can't even tell what side this used to be. Maybe. But I can't tell which is lateral, you know, it doesn't matter. So I would say unilaterally, the left half of the mandible is massively expanded and replaced. The bone is massively expanded and replaced by an infiltrative multinodular mass that is extremely firm, poorly demarcated, and kind of dark red, black, gray on cut section. Does that make sense? So I'm choosing every word for maximum impact. Every word in there has meaning. Multifocally, replacing, effacing is a large, well-demarcated, multinodular, multifocal mass. It's this color, it's this texture. It's pushing the teeth out of the way. Does that make sense? Questions about this? Anybody know what this is? This is not an osteosarcoma. This is a food animal. Food animals die from infectious things because we eat them before they get cancer. One of my favorite things about pathology is the way we name things. We often name diseases very descriptively. So if you were going to name this disease based on what I'm holding right here, what would you call this if you were a silly person or a pathologist? This is lumpy jaw. Have we heard of lumpy jaw? This is a bacterial infection of ruminants, most commonly cows. So these are all granulomas. This is chronic granulomatous inflammation that is replacing the bone of the mandible, is eating the bone. Yes.
I'm assuming that would be the one that alive or dead.
Very much so. He was probably euthanized for this reason. At some point, you're not going to be able to eat if your mouth looks like this. This is her case. Anything else you want to tell us about it, like the history? A legal cow?
Yeah, because they were suspecting that the cow was not eating well because the owner was not feeding it well, and it had like when we like externally when we saw there were like multifocal round lesions on the left side, and it was very
His face was deformed.
very deformed. It was like very enlarged on the left side, and when we started dissecting, it was like oozing stuff coming out. It was on the muscle. Then we started deflecting the muscle, and it was like this. Yeah. It was
Beautiful.
Yeah.
It's a beautiful lesion. No, this is actually a lytic lesion. We are destroying bone. We're replacing bone with granulomatous inflammation and fibrosis. So this is an important concept that we'll discuss ad nauseum when we talk about chronic inflammation and neoplasia. This is chronic inflammation. It looks like cancer. Cancer can look like chronic inflammation. Those two are almost always differentials for each other because they're both proliferative. They cause lumps. They can really distort and destroy tissue. This is infectious.
It's from the infected wounds, right?
Yeah, I think
It's
the theory is like they choose something rough and it like pokes into their mucosa and inoculates a deep bacteria, and then this bacteria just takes over. It's like, I live here now. Your face is mine. Bring me another. Maybe. Yeah. Yes, please. Thank you.
See if I can take one.
I got plenty of volunteers.
if one cow is affected, it's spread easily.
This is not really a contagious disease. This bacteria, this Actinomyces bovis, it's in the environment. It's part of their oral flora. So it's really a single cow thing. It's a traumatic inoculation to the tissue. If you catch it early, can you treat it? So you guys don't know this about me yet, but you can't ask me live animal questions.
Okay.
I would treat it by euthanizing the animal. Euthanasia can be therapeutic as well as diagnostic. There is nothing that euthanasia won't cure. Yeah, I don't know if that would be treated or how it would be treated. It's a difficult bacteria to deal with. I do know that. I think once the person notices it, by the time that it becomes apparent that the animal is sick, it's going to be so far gone that there's no purpose in doing anything but euthanasia. All right, my friend Ichabod. Where's his liver? Can I have his liver, please? Okay, so my friend Ichabod here, I was very moved by his plight. I am actually on biopsy duty this week, so I am only looking at tissues from live animals. And I got Ichabod's toe on Wednesday?
Yes.
Tuesday or Wednesday? I got his toe on biopsy, and it came with that history of he has differential temperatures in his right and left leg. He auto amputated his own toe, so he auto mutilated, bit off his toe. They couldn't find it, so he either lost it in his enclosure or maybe ate it. No judgment. It's a lifestyle choice. So I got his toe. He did an amputation, and then the vets went back and amputated it like to the joint, like they did a real job. But actually on biopsy, he did such a good job amputating his own toe that when I was looking at the two ends, I couldn't tell which was his and which was theirs. It's pretty
Good
clean.
job.
Pretty clean, yeah. All right, so cool case, not a great sample, didn't preserve well. This is gout. He has a white substance thickening his pericardium. It's kind of hard to see. There's no way in Zoom land you're going to be able to see that. If you use your imagination, maybe it has a little bit of a green texture. Not a great sample. There was a plaque of it on the liver that appears now to have come off, but it was a white plaque on the surface. I promise it looked just like the pictures. Yeah, and the other thing in this guy, if you feel around his great vessels, he's got some little crunchy spots. So this is an older bird. Atherosclerosis and arteriosclerosis are very common in old birds. It does not usually kill them. It's usually subclinical, actually. So old parrots, pretty much every old parrot I've ever necropsied has had some degree of afro. All right, questions about this guy, gout.
Can we see anything? Like just from this one in particular, from his toes? Got really.
So not really. It looks like they didn't really open any joints. He does have, on this foot with the amputation, he does have one toe that's starting to get pretty discolored. So usually articular gout, you'd be able to palpate that his joints are swollen. I can't really feel like they're swollen. That one maybe feels a little bit big. The one that's dark actually feels a little bit swollen. So potentially, but you would need to really cut into those joints to see it. Good question. Yeah.
You're in the amplitude is so because it was.
It hurt. Yeah. Either from gout or from a bacterial infection. I can't answer that because the part of the toe I got had no findings. There was just a little piece of dead bone and like a clean cut. So I didn't see any inflammation. I didn't see any cancer. I didn't see any gout.
For the different.
Yeah.
You suspect that condition is like.
No, we talked about this in one group. Why would one limb be cold and one limb be warm? So that's a good point. The warm leg could be too warm. It could be inflamed. Or the cold leg could be too cold and it could not have enough blood supply. There was a thing in the history. I'm sorry, that history was written in Dr. E's. I gave it to you anyway because it's good practice. You're gonna start writing like that. Don't read like that. The history had something about when they did the surgery and they amputated his toe, they cut into it, it didn't bleed. That's a dead foot. Okay.
I have a question about like did you actually measure? Or was it
Clinicians. They did. They probably just, oh, this foot's cold.
okay?
Let me do my internal control check the other foot.
Did he die or was he euthanasia?
I don't know because they didn't check the box on the sheet that gives me that information, and this was not my case. Do you remember? So after they did the biopsy, he basically went downhill really fast and either died or was euthanized because he has gout and he was systemically ill, right? His toe is the least of his problems. Another.
Can you treat it?
I don't know. We did. Did he? He came from the aquarium.
Yeah, I was gonna say.
I mean, we want to the wet lock.
Oh, the reptiles.
No, I don't want to do the reptiles.
These are just reptiles.
The reptiles all have melanosis. That's it. They're black inside. Kidney. Oh, I love this one. This has pus, so it's the best thing today. All right, so this was tissue from a horse. Make sure you guys pay attention to those history and signalment papers I give you. There's a lot of information in there. Did anyone notice the age of this creature? 11 what? Was he 11 months? Was he that old?
10 months.
Oh yes, okay. So youngish, not baby, but young.
Yeah.
So that's important, right? When we're working through that damn it V list, if I have a young animal, I'm going to prioritize congenital things, infectious things. I'm going to deprioritize degenerative things, neoplasia, metabolic, just kind of anywhere it could be on things. All right, so this kidney, whoa, it's splitting in half. I'm so sorry, baby. It's so beautiful. All right, so this kidney, the way I would describe this, I would say the renal parenchyma, primarily the cortex, is multifocally expanded by numerous small white foci ranging in size from a couple millimeters up to that biggest ones, maybe a centimeter. On the cut surface, these little nodules are white, soft. There's a creamy white, kind of liquid, almost cottage cheesy material that can be expressed out of them, but please don't squeeze it because you'll hurt it. I would say maybe 20% of the kidney is affected. We've lost maybe 20% of renal parenchyma, right? This is a classic multifocal lesion. It's everywhere, but it's not diffuse. There's normal kidney in between all of these spots. What else do you want to say about this? This is a really classic embolic pattern of lesions. You guys know the word embolic, like an embolism is a blood clot traveling through your blood. So an embolic pattern happens when things are coming from the blood and seeding organs. It's like a shotgun blast pattern. We see it most in organs with heavy blood supply. So kidney, liver, lung are the big ones where I see an embolic pattern of lesions, also spleen. This was a acute bacterial infection. This was Actinobacillus infection, which kills a lot of young horses. Because of this pattern, I can tell that this bacterial infection was in the blood. This animal is septicemic and bacteremic. Because of this pattern, it tells me this came from the blood, so there's bacteria in the blood. That makes sense? So there's a lot of diagnostically relevant information in the stuff you're describing. If you describe an embolic pattern or a miliary pattern of lesions, you're telling me, I think this came through the blood into this tissue, not through some other route. Versus if this kidney was most affected in the pelvis, I would think, oh, something came from the lower urinary tract and crawled up, right? So lesion distribution can give you a lot of information about the cause. Yeah.
So does the term embolic, is that like a diagnostic description, or that's still a description?
It's a description, it's an adjective. Yeah, embolic just means that it's got that shotgun pattern that's following the distribution of blood in an organ.
The 20% coverage, is that like estimating if all the dots were put together, it's just the surface area of each dot. It's not like
Yes.
how much area has dots. Because
It's
dots are all
both.
over the kidney, but they're not.
It's both. Yeah, I'm looking at how much normal kidney tissue is here. There's normal kidney tissue in between all the dots. If I could take all these dots and put them all together over here, it would be about this much of the kidney. And that's also important information because there's something called the reserve capacity of every organ, which is what percentage of organ can you lose and still be functionally alive? In the kidney, does anybody know what it is? You can lose a lot. You can lose one entire kidney and part of another kidney. So if both kidneys look like this and they're only, 10, 20%, this animal might have died of renal failure, but it didn't die from compromise of the amount of tissue. It died from septicemia. Does that make sense? Other questions?
Would you expect to see that same pattern on all the highly diffused organs, or
Often, yes. Some agents like certain organs. So Actinobacillus really loves the kidney. It's its favorite place. So each tissue has a different microenvironment that some organisms like to call them, and others don't.
Would the prevalent nodules like that present differently in different organs? Like, would it be different with spleen or have more?
No, again, there is some organ specific responses, but you're not going to learn that or worry about that until next year. Right now, everything we're talking about is generic. It could happen in pretty much any organ, and if it can't, I will let you know. Where's my next beast? Quick, we only have 5 minutes. We can do one more. I'll be more organized next time. This is the first time I've done it this way. How do we feel about this format?
I like it.
Okay, cool. Ugh.
Yeah.
Okay, so again, I'm on biopsy. This is a biopsy that came to me. This animal is alive. For now. They might not be after they read my report because it's not right. Okay, so we have, could anybody tell the organ? This used to be a liver. There's some normal liver. What is all this? That's omentum and it's adhered to the surface of the liver. So if you describe to me an abdominal organ that has omentum adhered to it, firmly adhered, I can't peel it off, it's stuck. That tells me this organ has ruptured and bled because it is the omentum's job to act as a Band-Aid and stick to things and cover them. So this is a ruptured bleeding mass in the liver, I can tell that much. Uncut section, ew, right? What do you think about demarcation for this? I think I would accept either answer because look, come closer, really come close. Over here, it's pretty well demarcated. I can draw a line around where it starts and stops, right? I'm even pretty sure if I get really close that I can see a little connective tissue capsule around part of it. So it's partially encapsulated. That would be my descriptor. So over here, pretty well demarcated. If I come over here, I can draw a line around here, but when I get to this area, ooh, it gets a little squidgy. So there can be regional variations. This is a tumor. Did everybody get to that much? This is a cancer. So most of it looks pretty benign and well demarcated, but I'm really concerned about this area over here because that looks like invasion. We've gone through the capsule and we have abnormal tissue outside of this more well demarcated area. So here it's well demarcated. Here it's poorly demarcated. We have regional variation and demarcation. Other descriptors. So let me start with my big, what would my first sentence be? I can't tell what lobe this is, so I'm just going to make one up. I would say focally, massively expanding and replacing whatever lobe this is of the liver is again, it's focal, large, maybe like softball size mass. Uncut section, it's fairly well demarcated, but there are some areas where individual nodules are seen outside of the main mass. It is partially encapsulated. Uncut section, the tissue is extremely soft. It's friable. It is multifocally discolored, yellow, orange to tan to black in some areas. And this little nodule right here, this is my favorite guy. See him? Oh yeah, right there. See that little dot in the middle? Can everybody see that that looks just like a belly button? That's umbilicated. So the little nodule outside the main nodule has umbilication, which is an important feature to describe for some neoplastic masses. So that's how I would describe this. This is a hepatocellular carcinoma. I would also describe the omentum firmly adhered to the surface of the mass. I can't tell what percentage of the organ is affected because I don't have the whole organ. We've cut off parts of it because it's a biopsy. They amputated this part, rest of the liver is still in dog. Hepatocellular carcinoma, bad news. Spleen. The spleen contains multifocal, small, raised, variably sized, ranging from 1 millimeter, 2 millimeters, up to a centimeter, a little greater. They are firm, uncut section. They have the same color and consistency as splenic tissue. They do go into the parenchyma uncut section. This is benign lymphoid hyperplasia. This is no big deal. That's going to kill the dog. No big deal. Nope. This is an incidental finding. But they sent it at the same time because they were like, uh-oh, masses, masses.
So did they probably not know about the splenic stuff until they got into?
I imagine they did because they probably would have done ultrasound before they did surgery on this thing. Like you wouldn't amputate this during an explore. That would be a peek and shriek and like refer to a surgeon. Livers bleed a lot. They're scary to cut. I wouldn't. I would not.
Is there any way that in the actual operating room, you can tell if it's something that's cancerous? Versus
Yes.
like waking
Yes,
up?
Cancer Week, we're going to talk about morphologic hallmarks of cancer, how to tell things that are benign from things that are malignant just by looking at them, more wizard stuff. So that when you guys open and you'll know like, oh, I see this giant thing with omentum adhered to it and it's really soft and feels like it's necrotic inside. I think this is bad news.
I feel like if you were the surgeon, you would recognize that from the hospital.
If I was a surgeon, I don't want to play that game. Yeah. Postpartum spleen, yeah.
Yeah, like it seems very.
It's pretty contracted, but it's also like formal and firm. Did everybody appreciate the two hearts, the fresh heart and the fixed heart? So the things I'm going to show you in here are going to be anywhere on that spectrum, from super fresh and rotting to have been fixed for generations. I don't know. All right, I think we're done. Go put this back where you found it for the next group. Thank you all for your patience while we experiment with this new format. Yeah. Oh, yeah. Okay, this was a goat. Did everyone meet my friend? Barry the botfly? Oh, here, does anybody want him? You can keep him. Fine. Here, pass him around. Take him, pass him around.
Okay.
Just so much drama. That came from the horse stomach. That is a horse stomach bot. They are so common. Almost every horse stomach I open has at least one of those. That one literally only had one. It's right there. Yeah, all the time. All the time. Love to hate them. All right, we have 2 specimens here. This was a sheep goat. Show. I don't know. It's some small ruminant. Did everyone see the melanosis on the tongue?
Yes.
Easy. Done. All right. Did everyone find the lesion on the pluck? A little more difficult. Not sure. All right. So this is pluck. We have tongue to lung. So you can find a bunch of organs. We have trachea. We have esophagus, full length. We have aorta here. We have lung. We have heart. And then we have this thing, which is, if we're anatomically, so this is the way it is in the animal. So we are cranioventral in the thorax. We're cranial to the heart. It's the thymus. So this tissue right here is or was the thymus. And does it look like a normal thymus? What's it look like? Describe it for me. Nodular?
Enlarged.
It's very enlarged. It's usually pale because it's lymphocytes. I would call it multicystic. It's got little empty spaces in here. See that? That's a little cyst. That's a little cyst. Let me see if I can do this. Everybody see all those little holes? It's cystic. This thing right here was probably a big hole, a big focal cyst, all of that right there. So it's nodular, it's multicystic. What about texture? Is this thing holding together real well? Soft, firm, hard? It's soft. Yeah, you didn't touch it. You guys should touch everything always. And on necropsy, put on gloves and be like, that's how you're gonna learn normal. All right, so we have we added or lost something from the thymus? We've added. So what are some options of things to add? Could add fat, could add inflammatory cells, we could add tumor cells, we could add fluid, we could add blood, we could add pus. Do we have a favorite for this? What do we think this thing is? Cancer? Do you know what cancer of the thymus is called? A thymoma? This is a thymoma. They are very common in sheep, goats, So let's make it a goat. Do you remember if it was a goat or sheep? It's probably a goat. Playing the odds is a goat because they get these like it's their job.
So you're saying that most food animals don't live long enough to get.
I did say that, but we don't really eat goats. They're pets.
I agree. But my understanding is that the thymus only sticks around while they're relatively young.
Common misconception.
Okay.
You have it for life. It is big when you're young and active, and then there's an I word, you know the I word. It involutes, so it shrinks down and becomes atrophic. We're gonna learn about atrophy next week. That's an example of physiologic atrophy, but it's still there.
So
There's
still
still
there.
remnant
It's still
tissue in there. It's just small and savage. And just waiting to become a cancer. Done with. Good one. All right, so this was a young calf. You can tell it's young because if I've told you this is a cow, these are not the size of adult cow lungs. What did you guys notice about this? What did you describe? I would not use friable. I don't think this lung is falling apart. In fact, the lung, if you think about the normal microanatomy of the lung, it's a lot of collagen, elastin. It's pretty tough. So if I can pick you up by your tissue and shake you, you're not friable. If I did that to that liver tumor, I would end up with like a little pinch of liver and it would just be like, no. So it is not friable. It is soft. It is soft, but it is not friable. What do you guys think about the pattern or the distribution of lesions? We've got kind of a gradient going on here. What do you think is the more normal, the cranioventral or the caudodorsal? Caudodorsal is more normal, correct? Not absolutely normal. No, I can't feel any air. I haven't showed you guys how to fondle a lung yet, have I? It's important. Don't laugh, it's serious. Lungs should know how to be fondled appropriately. With consent. All right, so you're gonna take your lung, you're gonna, my hands first. This is your lung. You're gonna go like this and let it just like gently slide through your fingers. And you're feeling for a couple things. So it's a texture thing. You're feeling how soft, are there any lumps or bumps or nodules in here? And then also, can I feel the normal crepitus of the lung, which is the little air bubble alveoli popping? That's normal. A normal lung should have crepitus. So when you feel it like this, you're feeling for those little Rice Krispie bubbles popping. Whenever I'm palpating, I like to not look at the thing. It helps me feel it if I'm not looking at it, I think. I'm also really bad at palpating. Could not pop at me way out of a wet paper sack. That's why it has to be dead and I have to be like inside of it to be like, oh yeah, that kidney's enlarged, I can feel it. All right, so pretty significant texture difference between the caudal lung and the cranial lung, right? Could everybody appreciate that? This is soft and fluffy and a little bit aerated. This feels like liver. This is solid and dense. There is no air in here. So I agree, this is the abnormal part of the lung. All this dark red, it's abnormally firm and there's no air. Back here, we're still soft and fluffy. So I asked you, I think with this one, to think about routes of infection into the lung. We shout out some ways that you can infect the lung. What are portals of entry? You can come in through the airway. You can come in through the blood. Open question, maybe. Yeah, lung lymphatics not super prominent. Penetrating injury, extension of inflammation from, like, if I have a liver abscess that pops into my chest, I can infect the lungs that way. Good. The two big ones are it's coming in through the air or it's coming in through the blood. Where are particles going to settle if they're coming in through the air? They're going to settle cranioventral. If I'm an animal, I'm shaped like this, and I'm breathing in, the particles are going to settle with gravity. They're going to go to my cranioventral lobes. So inhaled etiologies often cause this pattern of cranioventral disease. If it's coming from the blood, where is it going to go? Everywhere. Where's it going to start? Where's the blood come in?
The edges.
The edges? Over here? What is the blood supply to the lung? The hilus. We're coming in at the hilus. So disease is going to start kind of dorsally and it's going to spread caudodorsal to diffuse. That's the classic pattern for bloodborne. So what do we think of this guy? He inhaled something. Yeah. This is a calf. This is pretty classic shipping fever. Causes a bronchopneumonia. We call it bronchopneumonia when it has this cranial distribution to tell you, hey, it's coming in from the bronchi. It's something inhaled. It's probably something like a virus or bacteria, an upper respiratory virus. Shipping fever, classic. Questions? Bless you. I'm just tired. It's been a long morning. Can I do the hearts? Someone bring me the 2 horse hearts. You may ask me questions about the exotics while you're both horses. Quick, run out of time. Exotic things have a coelom, no diaphragm, coelomic cavity, C-O-E-L-O-M. Nice. All right. This one's important because this illustrates a concept that we're going to be coming back to all quarter. I'm gonna show you things everywhere on the spectrum between these. This is extremely fixed. This has been sitting in formalin probably for a week or more. Look how different the color is. This is no longer the colors of life. This is now like an anatomy specimen. So you should be pretty familiar with tissues that look like this, but look how different these are from real life tissues, right? That fresh lung, that's the color of that really pink lung we did first. That's the color of something freshly dead. This is the color of something less freshly dead. This was Wednesday. But still, massive difference. You can tell if tissue has been fixed or is not fixed. There's also a difference in smell. This smells like rotting things. This smells like cancer, right? This smells like fumes and chemicals. The texture is really different. This is way firm. So just keep in mind when I show you guys fixed tissues, a lot of the things like texture and color are not going to be representative of what it really looked like when it was freshly dead. This is a freshly dead heart. This is a fixed heart. They are very different, but I need you to understand that I'm going to show you lesions anywhere between here. Does that make sense? And you're going to be like, but the color's weird. I'm going to be like, I know, that's fixed. Makes sense? Any question about fixation artifacts or postmortem changes or literally anything?
I had a question about the verbiage of postmortem.
Yeah.
So over in that corner,
Yeah.
There's the liver mass and then the spleen. And
Yep.
on your little prompts, it said
Yep.
something about postmortem.
Yep.
Because they have been removed from
Not a
their
thing.
blood supply.
There's no such thing as postmortem. That tissue came out of a live animal and went right into formalin.
Okay.
There are no postmortem changes. There may be examples of autolysis if someone took that out, put it in the fridge and forgot it for 2 days. It would start to rot, but it's not technically postmortem because the animal's live. Got me on a technicality there. I wrote those last night. I was like, it's 5 o'clock. I want to go home. Postmortem. Anything else? Other questions, other specimens you're dying to talk about? Last couple minutes.
You said that fresh heart is green. Is that just autolysis?
What is this? What causes tissues to turn green? Pseudomelanosis. There is no gallbladder in the chest that I'm aware of, especially in a horse. There's definitely not a gallbladder in the chest. This is pseudomelanosis. I put these tissues in a bucket with guts. This is bacteria digesting blood. Pseudomelanosis. I created artifacts for you guys to see. You're welcome. Good questions.
Tie-dye.
Yep. Pathology tie-dye.
Is there anything abnormal with that part?
Which one?
Point out the fresh shirt one.
This was just a disposal. This animal came in because it had a penetrating shoulder wound that was pretty deep and they euthanized it because of that. All of its internal organs were normal. It only had the one bot fly. No colic or anything. Very unusual for a horse. This horse does have a lesion, but I didn't tell you about it because it's really subtle. This came in for a rupture of the chordae tendinae. See that chordae is frayed and skanky looking? Frayed and skanky. See it? So that ruptured. But it was subtle, so I didn't want to torment you guys with that. All right. You're free to go. No more questions. Thank you guys.
Thank you.